Good afternoon, everyone. Welcome to the second lecture in our series of webinars for the Olongapo City Medical Society Cancer Awareness Advocacy. Before we proceed, let us begin first with the prayer by Alonzo Mendoza, followed by the Philippine National Anthem and the PMA hymn.
Let us put ourselves in the presence of the Lord. Almighty Father, we thank you for another day that will given us to spend happily with our loved ones and productively with our colleagues. We thank you for giving us again another chance to come another and find ways to celebrate your gifts and light, health, and knowledge. We give thanks for our organizers and our speaker for our dedication and advocacy of sharing information and awareness that will save more lives each day. We give thanks for today's participants for their enthusiasm to learn, to grant them the focus and the receptiveness for today's activity. Grant us faith, optimism, and hope to get us through each day, always with a renewed energy for life and armed with your guidance and love. This we all pray through your most holy name. Amen.
Mga kababayan, ang pambansang awit ng Pilipinas.
officially open today's activity, may I call our PMA Governor for Central Luzon and our immediate past President, Dr. David Calapatia, for his welcome remarks.
Good afternoon, everyone. I'm being heard. Thank you to the Central Luzon Medical Society and to our guests for being with us for the lecture on pancreatic CA. Is There Hope? To be given by Dr. Arturo Mendoza III of the Olongapo City Medical Society. Last July 30, Tarlac Medical Society invited us for the lecture on revisiting superficial fungal infection. And for August 12, the Nueva Ecija Medical Society postgraduate course, I Am For You, Complex Made Simple, Approach to Multidisciplinary Medicine. Let's have more of this medical collaboration for our camaraderie and hopefully not only medical lectures but more fun activities too, like cook fest, aerobic exercise, healthy living activities, or art. A special shout out to Dr. Alma Macaspac of the Pampanga Medical Society, or Dr. Michael Dizon of Angeles Medical Society, Dr. Elvin Clemente of the Bataan Medical Society, or Dr. Joseph Juan of the Bataan Medical Society, and Dr. Milet de Guzman of the Nueva Ecija Medical Society. Lifestyle Medicine of Dr. Ethel Vital Cornes of the Nueva Ecija Medical Society as well. Ituloy natin ang pag-iingat, pagpalain tayo ng Diyos. Marami pong salamat.
Thank you, Dr. Calapatia. So, a few reminders for participants for this webinar. Kindly turn off your webcams during the lecture, but you may turn your videos on during our open forum. Kindly keep yourselves muted during the lecture. Please feel free to type in your questions in the chat box, and I will be reading them all later during the Q&A part of our program. So anytime during the lecture, if you have your questions, you can type it in. And lastly, should you experience any connection problems, just log out and re-register clicking on the link or by manually entering the ID and password using the Zoom app. This webinar can also be viewed via YouTube Live. Cancer remains to be one of the leading causes of morbidity and mortality worldwide. The World Health Organization reported an approximate 10 million cancer-related deaths last year alone. The Philippine Health Statistics as of 2009 showed cancer as the third leading cause of mortality and morbidity in the country. These staggering figures cause quite an impact to us as physicians, and this has led the OCMS to focus on cancer awareness as one of our primary advocacies. This is a rundown of our topics for this Cancer Awareness Advocacy Lecture Series, which will be held monthly, highlighting the different cancers affecting our organ systems. I am sure you will all agree with me that gaining knowledge is the best way to beat this disease. The best defense is a good offense, and being proactive is the best strategic offensive principle we can use to win in our war on cancer. If you can recall, we had our first webinar on prostate cancer last June, care of Dr. Ian Alpajaro. Pancreatic Cancer Awareness Month is actually celebrated during November, but we will be talking about it this afternoon. Though not in one of the 5 top leading causes, this cancer continues to affect more and more Filipinos and is one of the cancers that can be successfully treated with early diagnosis. Thought of as an illness with a dreaded prognosis, synonymous with a life sentence, pancreatic cancer remains to be one of the deadliest of the cancers. We are so fortunate to have with us an expert lecturer to enlighten us about it today. Our speaker graduated from the University of Santo Tomas Faculty of Medicine and Surgery, finished his residency training in general surgery at the same institution, graduated as chief resident, further trained with a fellowship in laparoscopic and hepatopancreaticobiliary surgery, and a clinical and research fellowship in hepatobiliary and pancreatic surgery at the Seoul National University Bundang Hospital, Seongnam, South Korea. He is a member of the External Affairs and the Scientific Committees of the Philippine Association of Hepatopancreaticobiliary Surgeons Incorporated, and is a board of director of the Philippine College of Surgeons, Central Luzon Chapter, and the incoming vice president of the PSGS Central Luzon Chapter. He is a member of the International and Asia Pacific Hepatopancreaticobiliary Association, a fellow of the PAH-PBSI, as well as the Philippine College of Surgeons and the Philippine Society of General Surgeons. Our lecturer has 2 internationally published papers on pancreatic diseases, and here are his other research works. Fellow doctors and guests, it is my pleasure and a privilege to introduce an esteemed colleague, a brother in the field of surgery, and also my brother-in-law, Dr. Armin Mendoza.
Thank you, Dr. Manzo, for that very generous introduction. Share ko muna screen ko. Good afternoon to everybody, to all our attendees today, this very gloomy and rainy afternoon. First of all, I would like to thank the organizing committee, of course, headed by our president, Dr. RJ Manzo, for this very nice opportunity to talk to you today about pancreatic cancer. Now, RJ, okay ako? Audio?
Yes, you're clear, Armin.
Okay, sige. When Dr. Manzo talked to me and requested me to talk about pancreatic cancer a few weeks back, the first thing that came into my mind is what should I talk about? What should be the title? It's a very broad topic. There are many controversies regarding this type of cancer, but I decided to talk about mainly the generalities of it. Where are we when it comes to the numbers, the current diagnostic and treatment modalities, and hence I entitled my lecture for today, Pancreatic Cancer, Is There Really Hope in Treating This Very Aggressive Disease? So I have no disclosures. Let me start off with this slide. These are very famous personalities, celebrities from all over the world. I'm sure most of you know them. This is Patrick Swayze from the very famous movie Ghost. Aretha Franklin. This is Alan Rickman from Harry Potter. This is the famous opera singer Luciana Pavarotti. The host of Jeopardy, Alex Trebek. And the very famous Supreme Court Justice in the US, who's a very active feminist, Supreme Court Justice Ginsburg, our very own Rudy Fernandez, the action star. Now, obviously, you know why all of them are in this particular slide. All of them were diagnosed with pancreatic cancer, different stages, different forms of treatment. Unfortunately, all of them succumbed to the disease. Some in a short course, short battle, some a little longer than the usual. Probably some of you are asking, why is Steve Jobs not here? Actually, Steve Jobs is here. He's a very different case when it comes to pancreatic disease. He was actually diagnosed with a different kind of pancreatic tumor, the pancreatic neuroendocrine tumor, not the usual pancreatic cancer. He was diagnosed 2006, I think, and he underwent liver transplantation even for liver metastasis, but succumbed to the disease in 2011. Now, when we hear about pancreatic cancer, it was stated by Dr. Manzo a while ago. It's a very devastating diagnosis for all of us, for all of our patients. But if you look at Justice Ginsburg right here, she was diagnosed 1999, and she lived up to 10 years from the time of diagnosis. Now, some of us here today might have patients, colleagues, or even friends who are diagnosed with pancreatic cancer. And for me personally, I always tell my patients that Although the survival is not that good, take a look at Justice Ginsburg right here. She's survived 10 years and even more. And she's actually considered an outlier, an exception to the rule. And I always tell my patients that there's no reason for you not to be that outlier, even with diagnosed with this very aggressive cancer. So a little overview. Pancreatic cancer is known to arise slowly, silently, insidiously even, and usually when diagnosed, they are have already invaded locally and spread distantly. By statistics, it's the fourth most common cancer-related death in the United States, following lung cancer, breast, and colorectal. Second most common GI cancer, following colorectal. And the mortality rate follows the incidence rate. So what do I mean by this? If, for example, in 2021, 50,000 people are diagnosed with pancreatic cancer, in the same year, almost 50,000 will die from it. It doesn't mean that all the patients diagnosed this year will die from it. Probably my patients not from 2019, from 2017, that will eventually die from it in 2021. It just shows that people diagnosed with pancreatic cancer, usually it's the cause of their death. And surgery is currently the only potentially curative treatment. Unfortunately, only 20% of patients are good candidates for surgical resection. Now, what are the numbers? This is data from 2021 from the National Cancer Institute in the US. They ranked pancreatic cancer as the 11th most common type of cancer in the US. And they estimated over 60,000 people will be diagnosed in 2021. And in the same year, almost 50,000, nearing 50,000 will die from it, with a rate of 3.2% when it comes to new cancer cases. Now, this is what I'm telling you about, that the mortality rate parallels or equals incidence rates. On the right side, you can see that pancreatic cancer does not discriminate. Male, female, white, black, Asian, whatever race. Although there's a little predominance in males, over also predominance in African Americans, everybody can get pancreatic cancer. And in Asians, it was found that if ever an Asian is diagnosed, usually it's compared to, of course, the blacks and the Hispanics, lesser aggressive type of tumor, which is good for us actually. Now, this graph shows the estimated number of deaths in 2021 based on the actual 5-year relative survival of 10.8%. So if you look at the graph, this is again what I'm telling you, that the mortality almost follows the incidence rates. When it comes to the age, usually the elderly population are diagnosed with it. It ranges from 65 to 74, and the median age at diagnosis is 70. On the other hand, the median age at death is around 72 years old. This is current data. What about in the Philippines? Locally, well, this is the data. Actually, I was surprised na meron tayong data sa internet nito. It's from Globocan 2020 from the World Health Organization. The top cancer in the Philippines is still breast cancer at around 17%, followed by lung and colorectal. Now, pancreatic cancer falls under other cancers, which comprises around 46%. In general, for both genders, the top 5 most frequent cancers are breast, lung, colorectal, followed by liver and prostate. What about pancreatic cancer in the Philippines? It ranks actually 14th. So these are the top cancers. Pancreas is just the 14th. However, if you look at the cancer-related death rate, it rises to the 8th rank. So again, not a good sign when it comes to survival and outcome. And what about changes over time? This is a very good paper from Oxford, although a little bit old, 9 years ago. I put it here just to show you the trend of 5-year survival for the past 45 years for pancreas. From the 1970s, the 5-year survival was around 2.5%. And in the 2012, it rose to 8.5%. This is good improvement, although very small in numbers. But if you compare it to the other types of cancer, such as breast, in the 1970s, the 5-year survival is around 75%. It grew to 90%. And I believe in 2018, this is already 93%. So at least if you think about it, although small improvement, there is progress when it comes to survival. This is data from 2021 as well from the American Cancer Society, just to show you the survival changes in pancreatic cancer for the past 8 decades compared to the other cancers seen here. If you look at lung cancer, there was a very steep drop of death. Probably this can be attributed to high anti-smoking campaign. And if you look at colorectal cancer in green, there's also a steady drop in death rates, as well as stomach cancer or gastric cancer. Partly this is due to screening colonoscopy. We have our GI friends here today. And in screening colonoscopy, we can directly see cancers, either early stage cancers or even pre-cancer states. If there's a polyp, then you can remove it before it develops into a cancer. However, in pancreatic cancer, we don't have that sort of screening tool or colonoscopy. We are looking right now, probably in numerous research, but we don't have it as of this moment. And when it comes to death rates, the pancreas, there's been an increasing, slow increase in death rates, around 0.3% annually since 2000. Now, this probably mas maraming patients na diagnosed through more improved diagnostic modalities and screening. Okay, so this is an example of colonoscopy. You can see it right there. Before it metastasizes, before it, if it's just a polyp, it's just a precancerous tumor, and you can remove it. That's the reason behind the steep or the continuous decline in death in colorectal cancer. Now, this is a graph showing the funding for the different cancers. Again, sorry, this is US data. This is translated in millions of dollars. This is in 2014. Just shows you that breast cancer and prostate are the king when it comes to funding for research. And probably this is because of the sheer volume of breast cancer patients all over the world, as well as prostate cancer patients. And if you look at pancreatic cancer, it's way, way, way much lower when it comes to funding. And you need funding for research. You need research to find better cure. So hopefully this will improve in the years to come. Now, talking about risk factors for pancreatic cancer, there are two sets, no? Modifiable risk factors and non-modifiable risk factors. Smoking does not only cause lung cancer, or laryngeal cancer, esophageal cancer, it also causes pancreatic cancer. And one-third of cases of pancreatic cancer are attributable to smoking. However, if you stop smoking for 5 years or more, the risk decreases almost nearing the general population. This is cigarette smoking. There's no data yet on e-cigarettes or vaping. Second modifiable risk factor is obesity. Obesity increases risk by 12% compared to the general population. Chemical exposure and occupational hazards such as pesticides, asbestos, and lead have shown to be high risk factors in developing pancreatic cancer as well. On the non-modifiable risk factors, age, I mentioned, this is a disease of the old age, not all, but commonly of the old age. Race, I mentioned this already, there's a predominance in African Americans. Genetics, there are certain genetic syndromes that may predispose to pancreatic cancer. I will later show in the following slides. Diabetes, it's proven that 80% of patients with diabetes, 80% of patients with pancreatic cancer have either subclinical impaired fasting glucose or diabetes mellitus type 2. It was found out that diabetes has twice the risk of developing pancreatic cancer, especially if the diagnosis have been 5 years or more. Now, I'm not saying that all diabetics will have pancreatic cancer. Um, the risk is there. Not all will develop pancreatic cancer, but in particular, 5 years or more upon diagnosis. Chronic pancreatitis also happens in some patients. There's a subset of patients with this inflammatory disease. Not all again will develop, but if you observe them for the next 20 years, around 4 to 5% will have pancreatic cancer. Now, unfortunately, we don't have the advantage of colonoscopy. I said that a while ago. So we can only diagnose pancreatic cancer through imaging. And most of the time, pag pumasok sila sa clinic natin, usually they are with symptoms already. Rarely do we see patients na, Doc, I just want to have a CT scan just to check if I have pancreatic cancer. And unfortunately, again, it's usually at a later stage when they have symptoms. Now, one of the most common symptoms is jaundice, the so-called painless jaundice. We've read this in our books during med school. No? The reason behind this actually is when the cause is malignancy, there is slow growth of tumor. There's a gradual and chronic process causing the obstruction. Now, because of this slow gradual process, there's no tissue damage, so there's no pain. If you compare it with gallstone, for example, there's an acute obstruction. There's an abrupt obstruction. So abrupt distension causing tissue damage, hence there is pain. So that's the difference why there's painless jaundice. Covershare sign, we all know this. If you have a palpable gallbladder with mild jaundice and an ultrasound, there's no stone. That's a typical Covershare sign. Again, the pathophysiology behind it is what I said a while ago. Unintentional weight loss, like any other cancer is very alarming. Abdominal pain. Now, some patients would present already with abdominal pain. And when this happens, we think of an aggressive disease, usually if the tumor is advanced or involving the nerve plexus already, then you will have abdominal pain. Another non-specific symptom is nausea and vomiting. Now, there are patients that would still come in our clinic then with a CT scan, Doc, meron akong nakita sa CT scan. So those are incidental findings, and usually they are on the early stage and during screening. Now, I highlighted here new onset diabetes mellitus for the more than 50 years old. If a patient comes to your clinic more than 50 years old with a new onset of DM, that actually raises a red flag to pursue further workup. It doesn't mean to say again that that patient will have or has pancreatic cancer. It's just based on the theory that this diabetes of new onset might be a consequence of pancreatic cancer. So just work them up. Make sure that you're dealing with nothing else other than a diabetes mellitus type 2. Now, once suspicion is sufficient for pancreatic cancer, a high quality imaging is critical for diagnosis and planning. Now, usually patients initially undergo an ultrasound. It's cheap, it's fast, it's everywhere. It's relatively available and it's not invasive. However, if you recall the pancreas, it's sa likod siya, retroperitoneal in location. So there are bowel gases overlying it. It's really difficult to study if you're focused on it. So these are the reasons why it precludes its use as a staging modality. And so when we see this type of ultrasound, this is a Covershare's gallbladder. It's really distended with no stones inside. You have to make sure that you're not dealing with any other pathology. So after an ultrasound, we usually request for a higher imaging in the form of a multi-detector CT, in particular a pancreatic or a pancreas protocol. So I always tell this to our residents, you should know this type of protocol because there are 4 phases in this protocol. The non-contrast, arterial, pancreatic, parenchymal, and the portal venous. Now, these are very important phases to really determine where's the tumor, what's its relationship to the surrounding viscera, to the surrounding vessels, and ultimately know if it's really resectable or not, or if the patient's a good candidate for surgery. Now, here's an example of a CT. The pancreas is in the middle, as you can see, a very dilated pancreatic duct. You can see it, you can just imagine it. Now, next is an MRI, or with or without an MRCP. Actually, an MRI or MRCP is comparable when it comes to diagnostic accuracy to CT scan. The only advantage of an MRI is that pag merong lesions sa liver na you would want to make sure, is it metastasis? Is it really related to the pancreas or pancreatic tumor? Then it usually characterizes indeterminate liver lesions. And here you can see an MRCP. This is the typical double duct sign you read in our books. This patient is a 53-year-old with a ampullary mass. So you can see this is the first duct, the white one is a pancreatic duct. This is the CBD. So this is typical double duct sign. Again, ampullary or pancreatic malignancy. No. Next is a PET CT scan. Although PET in the middle, this is the PET CT scan. Shown here is a good uptake in the liver, and there's an uptake in the tail. So this patient has had pancreatic tail adenocarcinoma with liver metastasis. Although PET is available nowadays, it varies between institutions actually, and is not currently considered the standard of care for all cases. It's really important to request it usually for metastatic workup and prior to giving systemic or adjuvant therapy. Last is the endoscopic ultrasound, or EUS. This is actually a hot topic. We have our GI colleagues here today. I'm sure they're very familiar with this. Nowadays, it has emerged as a useful adjunct to the diagnosis of pancreatic cancer, especially for tumors less than 2 centimeters in size that can be missed by other imaging modalities. To give an idea, endoscopic ultrasound is similar to an endoscope EGD with an ultrasound at the tip. So you can perform numerous procedures via ultrasound. You can perform ultrasound, biopsy, drainage, as seen here. So this is the EUS, this is the tumor. And also you can see the relationship with the surrounding vessels. And however, the major advantage of these imaging compared to EUS is that for CT and MR, you can evaluate the entire abdomen as compared to an EOS. You're just focused in that area where the endoscope is inserted. So if you're going to ask me, are these modalities available here locally? Yes, the MDCT, we have it in one hospital. MRI and MRCP is available, but PET, I think in Pampanga or Manila, and then EUS also in Metro Manila. But we can request it easily nowadays. Sorry. This is a good paper published in Radiology comparing the different modalities that I've mentioned. Highlighted are MR and CT. As you can see, there's no significant difference when it comes to diagnostic accuracy and sensitivity specificity, since they are the most commonly performed modality for the diagnosis and staging of pancreatic cancer. The choice between the two actually determined by the availability of the modality and yung expertise na magbabasa or mag-i-interpret. And personally, I request for CT first, pancreatic protocol with or without an MR afterwards. Now, we do further diagnostic imaging to clearly define the tumor characteristics. If you're familiar with this image, this is from Netter. So, ito nostalgic sa image na yan. No? Maraming labels and all of that. It just clearly shows how intricate and intimately related the structures are to the pancreas. So particularly for the surgeons, knowing whether a patient is a good surgical candidate is one thing. Determining what type of surgery or what type of resection for the patient is another. No? So we assess tumor resectability, distant metastasis, and aberrant anatomy if there are any. It's like a blueprint for particularly for the surgeons doing the surgery. So these imagings are very important. How about screening? How do we screen patients? So 90% of pancreatic cancer is sporadic. And because of this, it can be considered relatively rare, though very aggressive. So because of that, not unlike breast or colorectal cancer, population-based screening is not feasible. because of the high likelihood of false positive. So a better method actually is selective screening. Sino ba yung mga patients na high risk groups? No? So listed here in the table are the patients who have high risk of developing pancreatic cancer. So patients with Peutz-Jeghers syndrome, they have numerous polyps all over the GI tract. Yung usual presentation nila are 100% or 100 times more at risk compared to the general population. Take a look at the relatives. If you have first degree relatives with pancreatic cancer, it depends. It should be 2 or more. So if you have 2 or more first degree relatives with pancreatic cancer, your risk goes up to 18 times compared to the general population. If you have a second degree relative, it should be 2 or more. So the risk is still high, 6%, 6 times the general population, but certainly not as high as 18 times compared to the first degree. And the question is, paano pag meron kang first degree na isa lang? So the risk is the same as the general population because that first degree relative of yours can be considered as sporadic type of pancreatic cancer. And you can see the other syndromes. When to screen, how to screen, what to use when screening. Actually, as of this time, there are no formal guidelines. The recommendation now is just to frequently follow up these patients, these high risk groups of patients, and then play it by ear. If you think an imaging is warranted, if there are symptoms, no matter how vague it is, then you pursue further workup. After screening and diagnosis, accurate staging is very, very important to determine the most appropriate therapy. So it would be surgery. I will discuss later. Is it a good candidate? Is the patient a good candidate for surgery or other forms of treatment? Unfortunately, when they come into our clinics, half of them will usually present with metastatic disease already. Only 30% are locally advanced, and a portion only in this pie chart, it's just 11% confined to the primary site or very early stage. It's that unfortunate, but we still get patients as good candidates for surgery sometimes. Tumor markers are also used in this type of cancer. And when we talk of pancreatic cancer, carbohydrate antigen 19-9 is the only biomarker that has recognized utility in pancreatic cancer. However, I would like to put emphasis on this. It is used only once a probable or definitive diagnosis has been made. It should not be used as a screening test. So if you have a high inkling of suspicion or probably a diagnosis has been made, then that's the time you request for CA 19-9. Its usefulness, however, is limited sometimes for 2 reasons. No? First is it's not specific. There are benign cases such as obstructive jaundice, no? Probably because of stone or a benign condition. Still, pwede mag-elevate to serum 19-9. So you have to be very careful, no, in disclosing the result to your patient. It doesn't automatically mean that they're dealing with malignancy. Sensitivity, on the other hand, 30% of pancreatic cancer patients sometimes do not elicit elevated CA 19-9. But in essence, the best utilization of tumor markers such as this one is to detect treatment response, post-operative surveillance, and detection of recurrence. So after accurate staging, tumor markers, getting the tumor marker levels, we go now to the different treatment modalities. So there are only 3: surgery, chemotherapy, and radiation therapy. Now, what are the principles of surgery? Listed here are the reasons for surgical resection. It is the only potentially curative treatment proven currently. And during surgery, resecting the cancer in its entirety, or en bloc, as we call it, with adequate margins, as well as hemakulane in lymph nodes all over the involved cancer. And after removing the cancer, reestablishing continuity, the reconstruction process of the digestive tract. So when you talk about surgery, who is a good candidate for surgery? Not all. As I mentioned, around 10 to 20%. The goal of staging process is actually classifying patients into 3 groups. I won't go into the details of this. They are just labeled as resectable, borderline resectable, or unresectable. So the type of surgery is actually based on the area of the tumor. And as you can see here, majority of tumors are located in the head, around 80%. There is an equal incidence in the tumors of the neck and body and tail, around 11%. Of course, when you decide to do surgery, the overall health of the patient is very important. Nutritional status, performance status as well, the ECOG status, and also psychosocial factors. The patient should be willing to undergo that major surgery. The patient should be willing to recover or should be willing to live, because there are patients that even if you do the best surgery, best treatment, their willingness to live is not there. So it's really very important, as well as the support group is very crucial, especially during the recovery process. Now, when you talk of surgery, the most common thing you hear is the Whipple procedure. Now, the Whipple or the Whipple's procedure, its technical term is actually pancreaticoduodenectomy. So as the name implies, these are the structures that you usually, or that are removed, as seen in the diagram in the dotted line. A little technical, but all of these brown parts here, including the pancreas and the gallbladder, are removed. It can be done laparoscopically, robotic, or open approach. And so when you remove it, these are examples of patients that we did. As you can see, there are 5 different pictures, but all of these pictures have different types of cancer locations. Some are in the head, some are in the ampulla, some are in the distal bile duct, but all of them underwent a Whipple. So sorry for those who are eating or having their early dinner. So this is an example of a resected specimen. This patient had a previous gallbladder surgery, so the gallbladder is not there. So as you can see, the rest have their gallbladder in place. Now, after removing or resecting the tumor, reconstruction, as I mentioned a while ago, is very crucial. So your resection part is very crucial. The reconstruction part is as crucial as the first one. So there are different ways to do it, but this is how I do it. So this is an example. You put the small intestine and connect it to the pancreas. So this is the pancreas right here, and then the bile duct up there, and then the stomach right here. So this is an example. This is very crucial because, especially for this part, imagine suturing a spaghetti noodle to a small intestine. So it's that soft, it's that critical, but in the end, it's very fulfilling. It would usually last us 6 to 8 hours surgery. Very crucial yung time na yun, kasi if it's proven that if you exceed 8 hours, the morbidity and the complications go up. Okay. Another type of surgery, especially for the neck, body, and the tail, is called the distal pancreatectomy. The Whipple is for the head or the proximal part. The distal is for the remaining part of the pancreas. So these are the structures to be removed. It can be done laparoscopic or open approach. I made a very, very short video just to show you how it's done. Here we did the laparoscopic approach. This is the intraoperative video. So we mobilize the stomach here anteriorly. This is the pancreas. As you can see, it's like butter posteriorly. It's highlighted in red. It's very soft. So we dissect it. We mobilize it from its attachments. The advantage of laparoscopic is it's very magnified. So you can see the vessel. So that's the pancreas, highlighted in red. We isolate the vessel. So that's a pancreatic. That's a splenic artery. We did here a vessel preserving distal pancreatectomy. There you go. That's a splenic vein. So you really can see it. Very delicate movements as long as you know the structures. When you isolate it, now we cut the pancreas. We literally use a stapler, like a stapler when we use in paper. No, you have to make sure that the tumor in red is in the part to be resected. So after isolating the pancreas, you insert a stapler. So that's a stapler. It's a triple stapler to seal the pancreas. You remove it, and then you release the remaining pancreas. And then shown here is the remnant pancreas in red. That's the vessels, and the stapler line in green. So it can be done laparoscopically. Faster recovery, keyhole or minimal incision. So they return faster to their daily activities. Now, current research focuses on determining the most effective approach when it comes to adjuvant therapy. There are different drug combinations, chemotherapeutic drugs, and listed here are the landmark papers. I just want to show you that actually changed the landscape when it comes to adjuvant treatment. When it comes to adjuvant treatment, you can either give chemotherapy or chemotherapy with irradiation. It depends, because radiation sometimes is required to further decrease the likelihood of recurrence. So I leave that up to our surgical and medical oncologists with regards to what type of therapy the patient needs. What about patients who are unresectable? For patients who are not candidates for resection or with distant metastasis, the primary goal is controlling the disease by probably palliative systemic therapy and alleviating their symptoms. Most common is the cancer pain. Patients like with unresectable tumors have severe cancer pain. So we start them with oral pain medications. I think Dr. Carla De Harris with us. We refer them to pain medicine. So they give them different kinds of opioids, narcotics, and all of those oral medications. If not, you can also do celiac plexus neurolysis. So you burn or ablate the nerves in that area to decrease the pain. When it comes to the obstruction, of course, nandiyan yung tumor, jaundice pa rin sila. The first thing that we offer is ERCP. So usually here in Olongapo, Dr. Aguilar does it. ERCP with stenting, as you can see here. We can either use a plastic or a metallic stent just to bypass yung tumor causing the obstruction. If the endoscopist is not successful, sometimes barado-barado na yung opening nitong area na to, then we resort to PTBD or percutaneous transhepatic drainage, biliary drainage. And the last one, as you can see, is in surgical bypass. If the two first modalities fail, then we do surgery. So we bypass it. Hindi siya makakain. Yung stomach, we use a small intestine right here, example, and then connect the gallbladder to the small intestine as well, para lang may drainage to alleviate the jaundice, pruritus, and all of the accompanying symptoms with it. Nutrition is very important, either enteral or parenteral. And in essence, even though they are unresectable, maintaining quality of life is of paramount importance for these patients. Down to my last few slides. How about survival? In general, the 5-year relative survival is not that good, 10.8%. This is from the National Cancer Institute. In particular, if you look at per stage, if it's an early stage, it goes up to 41% 5-year survival. However, once advanced or distant, it really drops down below 5%, around 3% 5-year survival. And if you look at the trend for the last 40 years, we can say that although it's pataas siya, going up, the numbers are not that good, no? But it's still a significant progress. No? Hopefully, in the years to come, we will have better outcomes as long as it's progressing. And then I keep on mentioning surgery is the only curative option. No? This is a very good paper from the guys at Johns Hopkins Medical Center. They reviewed 890 patients. They found out that patients resected or underwent surgery for both pancreatic and periambulary. Good yung 5-year survival, 23%. But if you look at pancreas specifically, it goes down to 17%. Translating it to number of months, for early stage, around 20 to 24 months. If you compare it, probably sabihin natin, baba naman, 2 years lang. But if you compare it to non-resected, just 6 months. Stage 4, unresected, 2 months. So no matter how ilang months lang siya, it's still significant when it comes to resected patients. Now, I would like to share this with you. This this is really hot off the press. No, This is the potential impact of COVID-19 when it comes to cancer outcomes overall, all types of cancer. Now, this is from the American Cancer Society, and they predict that because of this pandemic, there will be a drastic change when it comes to cancer mortality. Because of the lockdowns and inaccessibility to healthcare, there will be reduced access to consultations, which in return will cause delayed screening, delayed tests and diagnosis. And so when you diagnose them at a later stage, so you will be limited to the treatment modalities or therapeutic options, and postponement of surgery, delays in chemotherapy and radiation, and in effect cause downstream increase in advanced stage diagnosis and increased cancer mortality. This is actually very scary when it comes to cancer care for our patients. So we should always remember that although the pandemic is still there, cancer is still there. So there in these times, maraming cancer surgeries na set aside or na delay, and resulting or probably resulting to this and in the years to come. So ultimately, it boils down to improving outcomes of our patients. Very important is early detection, like any other cancer. As clinicians, we should have that very high index of suspicion, which patients we need to further work up and follow up, and improve staging system, accurate preoperative assessment to avoid actually unnecessary tests and unnecessary surgeries. I put here multidisciplinary team, like any other cancer. I think this was mentioned by Dr. Manzo a while ago. Multidisciplinary team is very important in managing, especially pancreatic cancer. Not just a surgeon, anesthesiologist, oncologist, but also the pathologist, radiologist, and even a nutritionist should be involved in managing these patients. And overall, it would provide better outcome in the end. No, I mentioned here high volume centers. When you talk about high volume centers, these are hospitals that do Whipple 6 to 10 a year. Of course, here in our setting, it's not a high volume center. But let me share you this. This is a picture of me. Actually, I'm also that one in the background. This is a picture of me with my boss during fellowship training. We're doing surgery. And in this institution, I was very fortunate to, where I trained, we do 3 to 4 Whipple surgeries a day. And after a day's work, we're just gonna go out for barbecue and a couple of soju. And the next day, do it again. That's on a daily basis, 3 to 4 Whipples a day. That's literally a high volume center. And of course, their outcomes are great. Their outcomes are where researches are based on. And now I'm practicing here in Olongapo and Subic and some parts of Central Luzon. And I believe with proper training and with brilliant doctors here, different subspecialties and specialties being available, I think we can offer these treatment modalities and therapies to our patients with pancreatic cancer here locally and still have good outcomes. And again, going back to the question, is there really hope in the treatment or in treating our pancreatic cancer patients? In my personal opinion, I think there is, because no matter how small the window of hope is, I'm sure the number will get better in the years to come. And if you're talking about extending survival of these patients of ours for a couple of years or even a couple of months, I'm sure that would still mean a lot for them and their families. I think that's my last slide. Thank you for your attention.
Thank you, Dr. Mendoza, for that very illuminating and extensive talk on pancreatic cancers. Our participants indeed had a very productive afternoon, thanks to you. And most importantly, you highlighted that early detection gives our patients the best chance for cure. So the floor is now open for questions. Siguro I'll start na lang muna na questions. Ayan. Okay. Okay. Okay, siguro I'll start na lang. For patients with back pain, as a presenting symptom. How will you differentiate back pain which is relatable to a pancreatic cancer as compared to musculoskeletal or spinous?
Well, first we elicit, of course, the history of the patient, the factors or probable causes of the back pain, and the risk factors as well. If the patient has the risk factors that I mentioned a while ago, because I clearly remember one patient that's just a complaint, a simple back pain, and lo and behold, on workup there's a tumor. I'm not gonna scare our audience that all back pains will have pancreatic cancer, of course, but it actually depends yung sa scenario, the overall scenario. Meron pala siyang history ng trauma or static position, then of course you would shy away for doing further workup. But on the background of, for example, diabetes, and then on and off since probably for the past 3 months, and questionable weight loss, and all of those things, then it will lead you to which next modality to request. No? The typical pain of back pain in pancreatic cancer is boring pain. Sometimes it's just in the epigastrium, radiating to the back. No? So it's I talked to one patient of mine, ang sabi niya para siyang dinidiinan papasok sa likod. So that's a typical pain. Of course, it varies from one patient to another. Pero a simple back pain, I mean, we all have back pains. I have a chronic back pain myself, pero especially surgeons, that's right. Pero I think it's a case-to-case basis with the compounding other symptoms. And that's how you decide on workup.
Okay, thank you. Dr. Garcia is raising his hand. Dr. Garcia?
Yes, RJ. I'm sorry I came in late, but I found it very interesting, the experience that Armin had in Korea, doing at least 3 or 4 a day. Huh? It's not even a week or a month, but 3 or 4 whipples a day. So it's really a high volume center. Is there any way you can use your experience there, Armin, let's say in terms of demographics? So I know we're not as similar with the Koreans, but is there a way that we can use what they have in terms of to identify patients who you think would be high risk, let's say Filipino patients in particular, and there's a comment there, it is quite related, that there's no, for the Philippine setting, I don't know if there's any recommended screening program, but is there a way that we can come up with one, especially let's say for Olongapo, that will be cost effective and affordable?
Thank you very much, Dr. Garcia, for that question. Well, first, when I was there, I noticed that we were dealing with early stage pancreatic cancer. So I was really, wow, ang galing na detect nila kaagad. And I investigated and found out why CT scan is actually part of their of their usual checkup. So it's that rampant. I mean, you go to a general practitioner, for example, in one area, he or she will request right away a CT scan. It's just like requesting for an ultrasound. So most of our patients are early stage, and a lot of them are actually incidental findings. That's one thing I discovered. The difference sa atin, kasi sa Philippines, once with symptoms, that's the time we only request for consultation or go to a doctor. No, when it comes to screening, as I mentioned, there's no clear-cut guidelines. They still recommend screening patients of high risk in the high-risk population. In the Philippines, we're no different, as I mentioned also, from the Hispanics, from the Americans. So if you fall under that category, the high-risk population, if you have first-degree relative na 2 or more, if you have diabetes of more than 5 years, so and all of that, you should be frequently following up with your physician or your doctor, and then any symptom that the doctor detects, he or she should be decide whether or not to pursue that symptom and do a workup. But when it comes to screening, doctor, here in Olongapo, well, the typical scenario is this: abdominal pain, mayroong abdominal pain yung patient, goes to a doctor, the doctor requests for an ultrasound. So if the ultrasound shows nothing, it ends there. So I think as clinicians, we just don't look at the ultrasound that is normal. We look at the whole patient. If the patient somewhat falls under the high risk or the risky population, we follow them up. Probably after 6 months, we request for another if the symptoms are still there. If we're not at ease, then we can go higher up and request for a CT scan. So it's still case-to-case basis. There's no clear-cut screening guidelines for the general population.
Okay, thank
I
you.
hope I answered your question, Dr. Garcia.
Yes, thank you. Thank you. There's a follow-up, but I put it in the
Yeah.
chat box.
I will just a corollary to that question of Dr. Garcia. If ever, yeah, Dr. Paulo Villarreal, one of our gastroenterologists, most of our patients, Armin, really come from the GIs and the internists.
Yes.
So the early detection is really important here.
Yes.
So Dr. Villarreal is asking which is better if you will do a screening, CT, MR, or EUS, and corollary to that, what and when do you work up a patient with a family history? My dad's mother died of pancreatic cancer, I think 2019. And it was really a small lesion. However, it was in the body, already encroaching the celiac. That's why I had that question. So with these relatives with a family history, what is your recommendation?
Okay, so first with the question of Dr. Villarreal, what screening modality for small? First, I would still go for a CT scan. A CT scan and MR are actually comparable when it comes to the size, but less than 2 centimeter lesions, sometimes less than 1 centimeter lesions are missed by CT and MR. But if you have a high likelihood of suspicion, I mean, the suspicion is there, but cannot be detected by a CT or MR, then you request for an EOS. Because an EOS is very advantageous when it comes to smaller lesions, such as less than 2 centimeters. Okay. Next question. When? How soon? Okay. There was a very good paper in the US that they found out that pancreatic cancer, sporadic, develops 22 years. I don't know how they did it, but 22 years. Now, for a person who has a strong family history, a first degree, say for example, more than 2 first-degree relatives, getting a baseline CT scan is paramount. No, hindi naman kaagad na pagkapanganak niya, CT scan na kaagad siya. Since 22 years yung sinasabi nilang development of pancreatic cancer, their recommendation is some would say 30, some would say 40. So they're really not keen on setting a number. It's just that labeling a person as high risk is enough, and then doing the subsequent workup is another. So, done.
So these are for familial, suspecting familial.
Yes. But if you have a first degree na mention ko to kanina, first degree na isa lang, your risk actually is like the general population. It's not considered as high risk na 18 times the general population.
Okay.
But if you have 3, so sabi ko dun 2 or more, 18 times, no? If you have 3, the risk actually doubles. It becomes 36 times the general population.
Okay, thank you. Dr. Rojo has a comment here about ongoing trials that are exploring the use of clinical scoring systems for diabetes. As you mentioned, more than 5 years na may diabetes and more than 50-year-old na new onset diabetes. So ito nga, may trials na ongoing for possibly detecting pancreatogenic diabetes.
Yes, I agree with that. It's still ongoing. It's a very good trial. I reviewed it a couple of weeks ago. But the thing is, there's 2 theories to this, no? Why they're doing this? Diabetes and pancreas, they go hand in hand, no? So one theory is that because of diabetes, there's increased carcinogenesis that can lead to or insulin resistance, glycemic intolerance, causing diabetes. On the other hand of the spectrum, the theory is there's an ongoing pancreatic cancer already causing the diabetes. So it's just there, it's cryptic, it's developing slowly. So right now they haven't found which theory is the real cause, but this is a very good, promising study, this trial.
Okay, thank you. Okay, although not related to pancreatic cancer per se, is it true that when you sleep with a full stomach or drink a lot of alcohol, you can have acute pancreatitis? Siguro sama na natin dito yung question of Dr. Victoria. Would you say that diet full of high in grill or charcoal play a role in C of this type?
Yes, I mentioned barbecue and soju.
Yeah.
Dr. Victoria, gutom tuloy ako. First, the question regards to sleeping with a full stomach or drinking a lot of alcohol. Actually,
you know the one who asked the question. Eh.
yes, this is Ma'am Mendoza. Well, there has been a notion na pag natulog ka ng busog, yun yung sinatawag na babangungutin ka or magpa-pancreatitis ka, no? Actually, it's not because of full stomach and alcohol equals pancreatitis. It's actually overwhelming the pancreas by the bout of drinking spree or eating prior, and then usually natutulog kasi dahil antok eh. So that's the usual course of it. Pero in essence, any kumbaga ma-overwhelm yung pancreas natin. There are populations who are at risk for pancreatitis. That's the reason kaya sila nagpa-pancreatitis. Na-overwhelmed sa pagkain. Not really dahil sa natulog ka, ng busog ka, or dahil sa uminom ka ng before ka matulog. No? Second, yung ano yan?
Alcohol.
Mentioned soju. Would you say that diet play a role? For pancreatic cancer, when it comes to food, the high risk foods are like any other cancers actually, no, processed foods. Number one, proven yan. It can go as high as 50% risk. Processed foods, red meat, and fat, saturated fat is also one. There was even a study na butter, yung mismong butter is also a risk factor, but of course they can't quantify. But when it comes to food, the proven are processed foods, red meat, and saturated fats can play a role in in risk for pancreatic cancer. Is it true that Taiwan banned charcoal? I am not familiar with that, Dr. Victoria. But in Korea, they still use charcoal.
Okay.
But the thing is, sorry, just a note, pag nasa samgyupsal sila, tinatanggal nila yung sunog. So, mga part na burned fat, tinatanggal nila. So, I don't know if awareness pa yun.
Filipinos pa tayo, yung mga isaw, di ba?
Yes.
Dr. Garcia is raising his hands again.
Yes, Armin. So you mentioned
Yes,
for
doctor.
early detection, one of the best diagnostic imaging is a CT scan. So my question is, what's the minimum number of slices that you will request?
Yes,
I mean,
yes.
we have CT scans, but remember, there are different slices per CT scan. Or people might have that notion na pare-pareho lahat ng CT scan yan.
Yes.
So if you're after, let's say, early diagnosis, what's the minimum number of slices? That's one.
Okay.
And two, you mentioned a little while ago in 22 years. Is that like for you to develop pancreatic CA, will it take 22 years? Is that
Yes.
correct? Or that's only for those with high risk?
The study they mentioned for pancreatic cancer per se, doctor, wala siyang for high risk for general population. They just found, I don't know how they did it, pero that's the number that they found out. It takes 22 years to develop. Of course, hindi mo naman makikita na on the first year you would surveillance na kaagad. So, they just want to show na it really takes some time before it develops. And actually, when it presents, it's usually in the aggressive stage already. When it comes to the CT, doctor, the more important is the millimeter slice, 3 millimeter slice. But we have 64 slice CT scan. I'm not sure if there's higher here locally, pero as long as the CT scan can do 3 millimeter slices and do the 4 phases, kasi doctor, yung 4 phases, may timing ng contrast injection lahat yun eh. So as long as, I doubted kung kaya nila ng mga sa 12 slice CT scan yun, pero as long as they can do the 4 slices accurately and 3 millimeter slide cuts yung pictures, it's adequate as a pancreatic protocol.
Okay. No, so the reason why I'm asking that is like, you mentioned the high relationship between having diabetes and developing into pancreatic CA. So like say, for example, in my case, I'm a diabetic. If I had a CT scan done last year and it was normal, so would it be safe to say that in the next 5 years, that the chances of developing pancreatic CA is very low?
Okay. As I mentioned, doctor, there's no guideline in screening. But can I ask you a question, doctor? Are you considered as high risk aside from diabetes? Do you have probably a first degree or second degree who was diagnosed? If the answer is yes, then personally I do it on an annual basis. CT scan lang kung talagang high-risk population. But if not, we'll play it by ear as long as there's good glycemic control. And when symptoms come up, no matter how vague it is, then at the least I do an ultrasound right away and pursue it if may mga questionable or suspected findings. But if you ask me, like,
Okay,
for
thank
example,
you.
breast cancer, annually you do this and request for this and that. So pancreatic cancer, it's very loose when it comes to the guidelines.
Thank you. I think it's not comparable with how colorectal cancer is screened. The 22 years that you were mentioning is for familial pancreatic CA, wherein kasi sa colorectal meron din 20% na familial eh. So there are already guidelines set for this na 10 years younger than the initial diagnosis. So that's already proven. So in 22 years na yon, sometimes I think from what the paper of Dr. Mendoza is saying, if I'm 40 years old, I already have that risk because I already lived 22 years if I have two relatives already. So I think that's the point of the paper. Yun nga lang, we don't know how they did it, Armin. Dr.
Yes,
Delgado
yes.
is asking, is there any job or occupation which can increase pancreatic cancer risk?
When it comes to occupational hazard, it's more of the chemical exposure. So the chemical exposures that are proven to have high risk are the professions or occupations dealing with pesticides, some form of metallic, industrial. I'm not familiar with the MWP metals, lead and asbestos. So those are usually the chemical exposure put at risk. When it comes to occupation, probably radiation. I'm not familiar. Pero other than the chemical exposure risk, that's all I can say.
Okay. From Dr. Tina Trinidad, have you encountered pancreatic CA in pregnancy?
I had one patient. Actually, it's a malignant form of solid pseudopapular neoplasm. No, very young patient, siguro mga 30 plus, pregnant siya during that time. And what we did was borderline resectable siya during pregnancy. So we just did a temporizing procedure to alleviate the symptoms. After completion of the pregnancy, she underwent neoadjuvant treatment. And then, although it's not a clear-cut pancreatic cancer case, it responded to systemic therapy. And then eventually she underwent a Whipple procedure. That's a very memorable case for me kasi pregnant nga. Thank you, Dr. Tina.
Reportable case. Right? From Dr. Beverly Aguila, are tumor markers helpful for screening patients for pancreatic cancer? That's a very good.
Yes, I mentioned this a while ago. Unless you're dealing with a probable or a diagnosed pancreatic cancer, CA19-9 tumor marker is not used. There are conditions which are benign that can have an elevated CA19-9. So unless you're dealing with a probable, highly suspected, or a diagnosed cancer, pancreatic cancer, and that's the time these tumor markers are helpful, not for screening the general population.
Thank you. From Dr. Villarreal again, is it an absolute contraindication for surgical resection if there is already vascular invasion?
It depends, actually, Dr. Villarreal. There are different vessels that we watch out, or that we look for. It depends also in the degree of involvement, and it depends if we can reconstruct that particular vessel. But if we talk about the artery, or in particular superior mesenteric artery, it's automatically deemed unresectable. Not all vascular invasions are absolute contraindications.
So when you reconstruct this vessel, what do you use?
The best would be primary end-to-end, because they found out that if you use prosthesis like grafts, there's a high likelihood of the tumor, embolism. So if you can do it, resect it, a very short segment, and then primary anastomosis, that would be best.
Okay, thank you. Okay, from another gastroenterologist. For patients with pancreatic cancer who underwent Whipple already, is there a possibility of cancer recurrence to other organs? How high is the incidence, and can this be prevented with adjuvant chemo?
Definitely,
Corollary with that,
definitely.
Armin, do all
Mm.
patients who undergo Whipples automatically have adjuvant chemo?
Yes. Okay. So for the first question by our esteemed gastroenterologist, all patients undergoing a surgical resection for pancreatic cancer should undergo systemic therapy because of the high likelihood of recurrence. It depends on the stage, but on the average, it goes up to 35 to 42% in general. No? It goes higher, of course, if the stage is higher. And because of that, all patients should undergo systemic therapy with or without radiation. Um, ano yung question mo, Dr. Manso?
Do all patients? I think you
Yes.
answered it already.
Yes.
Dr. Manzo is asking also, how high is the incidence of this distant metastasis after resection?
Recurrence, regardless of local or distant metastasis, is around that, yung minention ko, 35 to 40. It's very unfortunate. Sometimes we get them early. A good example is I have a patient na early, very early stage siguro 1B. We did the Whipple, we did the systemic therapy. After less than a year, I see Dr. Romano here. I think it's that's our patient, Dr. Romano. Liver mets right away, no? On the other hand, I have a patient who went a Whipple and did not undergo systemic therapy. And I saw I saw the patient after 2 years outside. I mean, like nothing happened. So I think it really depends on tumor biology. But if you follow the guidelines, the standard of care is still adjuvant therapy for all patients.
Okay, thank you. From Dr. Acosta, in the case of a 70-year-old male with a stage 4 pancreatic cancer, on third cycle of chemotherapy, what is the expected result? And if the pancreatic mass shrinks, is he still a candidate for surgery?
Okay. So what is the expected result? The reason po, Dr. Acosta, for giving palliative chemo, this is palliative, stage 4 na siya, is extension of or prolonging the survival or life. No? And if you ask me if ever the tumor shrinks after chemotherapy, being a stage 4, then still he or she is not a good candidate, because even if you resect the pancreas, the mere fact that there is already distant metastasis, you don't actually help the patient when in terms of survival. So as long as the patient is stage 4 or unresectable, even if there's downsizing or nawala yung tumor niya after chemotherapy, stage 4 pa din siya. Stage 4 pa din po siya.
The
Thank you for
overall
that.
survival will not change.
Yes.
Surgery or not.
Actually, it's the same thing as doing a Whipple and then leaving behind just a microscopic part. So you really have to make sure na walang may iwan kahit microscopic, because it's just similar to not doing any surgery at all. It's that crucial.
Thank you, Dr. Acosta. You mentioned something about a figure from the 1975 to I think early 2000s that the survival
Yes.
is 5%, and then
Yes.
it got up to 8%, 8.5. What do you think is the reason behind this?
Well, number one, the patients diagnosed during that time compared to the patients diagnosed in the later time with these diagnostic modalities are higher. That's one. So we get them at an earlier stage. And earlier stage of diagnosis means better treatment equals better outcome. Aside from that, newer chemotherapeutic regimens, chemotherapeutic combinations, adjuvant therapy also plays a factor. So I think the surgery in 1975 and surgery now more or less is the same, but it's more of diagnosing them early and giving them the more appropriate adjuvant therapy.
Thank you. Any other questions? Habang ganado si Dr. Mendoza sumagot. I think you covered a lot of the generalities of pancreatic cancer. So Thank you for all those who asked their questions and for all participants tonight. Before we conclude, let me just award a certificate of appreciation to Dr. Arturo Mendoza III for his valuable contribution to the Olongapo City Medical Society and its cancer awareness advocacy through his lecture entitled Pancreatic Cancer is There Hope, given the 7th of August in the year of our Lord 2021, signed by yours truly and Dr. Marica Ridon, Secretary of Olongapo City Medical Society. Congratulations, Armin. Thank you. You enlightened
Thank you.
a lot of our participants now. Okay.
Thank you, Mr. President.
Okay. So next is favorite. May I ask the participants to turn on their videos for photo op and documentation? So nabanggit ni Dr. Mendoza kanina, yung hot off the grill sa COVID. We already have 11,000 for census for today. So back to back na 10,000 na. So ingat po tayong lahat. Okay? So let me just share. First page, we have 3 pages. Can you please turn on your videos? Antayin lang natin, ha? Okay, sige. 1, 2, 3. Next page. Okay, 1, 2, 3. Last page. Okay. Before we end, may I call on Dr. Jerome Acosta for his closing remarks.
Good afternoon, everyone. Thank you for attending this webinar. As always, the goal of these talks are early detection of your carcinomas, of your tumors, so that we can have better survival rates. There is hope, no, with better diagnostic modalities being developed. So there is hope in catching these things early. And isipin na lang natin kung si Heidelin Diaz nga nabuhat yung napakabigat na weight for Olympics, I think we can win with pancreatic cancer as well. So thank you for spending the past 2 hours with us, and I hope it has been fruitful. So thank you,
Wow,
Dr. RJ. With that, I close this webinar, and thank you, everyone.
Thank you. Once again, thank you to all our participants for sharing our Saturday afternoon. Please continue to join us and support our cancer awareness advocacy as well as our other activities for the year. Let us all continue to be proactive in cancer prevention. This has been your OCMS President and Moderator for today. Thank you and God bless everyone. Ingat po tayong lahat.
Thank you. Congratulations.
Congrats.
For the officers po, can you please stay lang for a while? Thank you.
Congrats, Doc.
Thank you.
Congrats, Armin, RJ.
Thanks,
Thank you,
Armin.
Doc. Thank you.
Congrats, Armin. Thank you.
Thank you po.
Yes.
Okay.
Level 1 is coordination.
Teka, leave na ako. Ba't ako dito?